All right, with that, we're going to transition to bones. Something still more straightforward, actually pediatric orthopedics. And we're fortunate actually to have Dr. Matt Oetgen, who is the Chief of Orthopedic Surgery at Children's National. And Matt, you got the mic and the floor here for half an hour.
Thank you very much. Sandwiched between autism and eating disorders. I've done this many times. So no conflicts here. So this is me. I'm actually a local kid. I grew up here in Fort Washington in Prince George's County. Went to school here at Gonzaga and then up and down the East Coast and trained in Dallas. Two daughters, Grace and Lucy. Grace is 17, and as you guys know who have kids who are that age, we are currently in the weeds of the college tour prep concern. So I am open to inside help for myself or my daughter because this is all new here. And then at the end, I'm just going to put a plug in for our new sports medicine center that hopefully you've heard about, but if not, I'll just give a little brief update on that. So Mark's segue was excellent because I think that, you know, as you guys all know and could tell me better, you guys see a lot of musculoskeletal complaints and pains, and there's plenty of studies that show how much comes into the primary care office throughout the year. Up to 6 to 8% to 10% of kids have these complaints. And I know that a lot of times these things are urgent complaints, and it takes a lot of resources for you to get them into the appropriate care or deal with this sort of thing. And so the purpose of this is to say, what are things that hopefully we can treat together, not bury our head in the sand and actually get kids going. And this sort of theme of sort of staying out of trouble is what I tried to choose. And I'm going to present some common, I think, office presentations and maybe give you some tips to say, what are things that you can be confident to sort of treat in your office or give parents feedback to say, this doesn't need to be seen by a specialist, but at the same time, give you guys confidence that you're going to not miss things that need to be treated, because I know there's sort of a yin and yang between, well, I can treat this, but I don't want to miss something that really needs to be treated, and orthopedics may not be as familiar. And so I think these are some common things that may help. So we'll go through this and then happy to answer questions. So the first condition is torticollis. I think everyone sees a lot of torticollis, and the primary sort of diagnosis that comes up in your mind is congenital muscular torticollis. And this is typically present at birth, but sometimes it can be seen later when they're a little bit older and people start to notice if it's a bit mild. And I think the anatomy of the sternocleidomastoid muscle sort of should be in your mind when you think about torticollis. So remember, the sternocleidomastoid muscle is this muscle that you see here on the screen, and it goes from the mastoid process and then attaches to both the sternum and the clavicle with two heads there. And it's on both sides. It helps you turn and tilt your head. And if you have a tight SCM muscle, it goes from the mastoid process to the clavicle and the sternum. If it's tight, it pulls your head, so it tilts it to the side it's tight at, and then it turns your head to the other side. So it tilts it to the side it's tight and turns it to the opposite side. And when I go in to any kid that presents with torticollis, I am talking to the kid and we're talking to the parent and looking at the kid, and I still do this in the office. So I take my finger and I put it and I say, okay, this is what it should look like. It should be tilted this way and turned this way. And that's an appropriate thing to do. So don't feel nervous about doing that. But when you see a child with a tight sternocleidomastoid muscle, but it's in the reverse direction. Okay, so it's a tight muscle like this child on the right-hand side, but they're tilted to the left and they're turned to the right. So that's totally opposite from what you would expect. That's not congenital muscular torticollis. And what's happening there is that muscle is trying to fight whatever deformity is happening. It's trying to stabilize the problem that's going on. And that could be things like atlantoaxial instability. It could be a mild or a non-displaced fracture. It could be some sort of instability or even infection I've seen. So if you go in and someone presents with a torticollis and they're 5, that may not be a red flag. It may just be noticed. But if they have this opposite thing where the tight muscle is on the opposite side that you would expect, I think that's something that you got to say. That's not torticollis that is easily treated with physical therapy or observation. And that's something you got to look out for and stay out of trouble. So I think just knowing where that muscle is and sort of doing that with your finger can help when you see these kids. And that second thing we'll talk about is clavicle fractures. So pediatric and adolescent clavicle fractures, very common, as you guys know, happens all the time. And I'll just say there's a very extremely, almost non-existent incident to non-union of the clavicle. They almost always heal and they almost always completely remodel, okay? And unlike adults, where there's studies that show if you have shortening of the clavicle more than 2 centimeters, it may affect the biomechanics of your arm and your shoulder. There's no evidence, and studies have been presented for the past few years at our meetings, that angulation or shortening of the clavicle leads to any disability in kids in the short or the longer term. And so surgery immediately or even in a little bit of a delayed fashion, it doesn't really help these kids. It doesn't help them return to play faster. They're still going to have to sit out a specific amount of time. So even if you have a very high level athlete, surgery is not the answer. If it's a painful non-union, if you have a rare kid who has continued pain, we can always fix this later, and early intervention is almost never indicated. This is an example. Boy falls off the scooter. He has this clavicle fracture. It heals 4 weeks later. There's no problem. And you may say, well, that's a pretty simple fracture. That's no problem. Well, here's one that's a little bit more. It's shortened. It's angulated. And 6 weeks later, you see it's already starting to remodel. It's nice and smooth. You see the bone there. And this kid goes back to playing football without any issues. So sometimes the adult providers who treat some adolescents, they fix these a lot, and that's probably not the right thing to do. So I would tell you there's almost no indication to operate on these things. If it's an open fracture, obviously, if it's a painful non-union later on, maybe so, but you can treat these kids with activity modifications and a sling for 4 weeks, and you can have them come back in 4 weeks and just make sure that it doesn't hurt when you press on them and they have full range of motion of their shoulder. And if it is, then they can go back to the play. And that's what I do. I never even x-ray these things in 4 weeks when they come back to see me, because if they're not tender and they're moving things, it's healed and they can go for it. So don't trade a scar for a bump. Sometimes they get a little bump there as it heals, and people don't like that. But I tell them, well, I'm going to leave a scar there, and it's going to be one for the other. And so I would say you can feel free to treat these things by yourself. The next thing, a distal radius buccal fracture. So I think there's confusion from our residents and from our providers about what is a buccal fracture and what can you treat and what you don't. So a buccal fracture and a torus fracture, same thing if you've heard of that name. And this is what it looks like on the screen. It's basically one of the cortexes is compressed. You see there on the arrow, there's a little compression in the back side of that bone. And then the other cortex is completely intact. So it's straight. You can see that white cortical line is completely intact there. This is an inherently stable fracture. It's not going anywhere. It's not going to do anything. And this thing heals no problem without any issue in 3 or 4 weeks. It's usually in younger kids, so that's why it helps that it heals very quickly, but it heals very quickly without a problem. Here's a 6-year-old boy that even has a fracture of the ulna, but when you look at the lateral side, the lateral view, this is a buccal fracture of the distal radius, completely intact anterior cortex, a little buckling in the posterior cortex, and if you treat this kid with some care, 6 weeks later, it's completely healed. He had a wrist splint, and he's back to normal without much issue. Here's the buccal fracture on the left, and on the right, pretty simple fracture, but that's not a buccal fracture. You can see there's a mild translation of that distal fragment on the other, a little mild step off on that anterior posterior view. And on the lateral view, you can see the fracture line goes all the way through the anterior cortex where that little X is. So this fracture does not have a stable cortex. This has a chance to move or to shift if it's treated in a way a buccal fracture does. So I would say there are multiple studies that give plenty of guidance on how to treat these in orthopedics literature, in the pediatrics literature, and in May at our annual meeting, there's a huge study coming out from the British, NICE, their national health center, that they looked at about 20,000 kids with this. and treating these kids with either a Velcro wrist splint, or in the British study, they just did a loose ACE wrap on the kid. There were no problems. They had no issues with these kids. 2 or 3 weeks later, they're usually non-tender. They don't need they don't need a cast. They don't need further x-rays. They don't really need any follow-up at all. And so if you get an x-ray and you see that, or it's reported as a buccal fracture and you talk to the radiologist, you really don't need to treat this like a traditional wrist fracture that may displace. You can treat this with a wrist splint or even an ACE wrap, and they should be totally fine. So don't over-treat these injuries. Kids don't need x-rays. They don't need casts. They don't need to go to the emergency room for those. So slip capital femoral epiphysis. Again, I think probably it's common enough here in the area that we see it. As we all know, this is a displacement of the proximal femoral epiphysis through the growth plate. So the ice cream that's on the cone sort of starts to slide through that growth plate, okay? Usually happens in boys 12 to 16, and girls a little bit younger, 10 to 14. And typically we see it when kids who are obese. You can see it in skinnier kids or younger kids when it's associated with an endocrinopathy, but it's usually in this sort of adolescent period, when, especially in obese kids. And the problem with this is that it can lead to really progressive deformity of the hip, and it can lead to really severe hip disability later on. And the worst is that the blood supply can be affected. And when you have a blood supply issue and you have issues with the femoral head or the ball and socket, there's really no good answer for that. And they have severe disability down the line. That's why whenever we see this, we really need to treat these kids. We really need to treat these and stabilize these. So the 2 tips I would say is this, and we still see this even though people talk about this. This often presents as knee pain. Oftentimes it doesn't have it. Kids don't have hip pain. They have knee pain. And if it's an overweight preteen kid with complaints of knee pain, they need a hip x-ray to check for this slip capital femoral epiphysis. I've still probably once a year get kids that are sent to me who the SCFE, the slip capital femoral epiphysis, was discovered when they were put on the operating table to get their knee scoped, and the orthopedic surgeon couldn't get their leg up to get the scope in their knee because they were complaining about knee pain. And then they wonder why the hip doesn't work. They get an x-ray and the kid actually had a SCFE and not a knee injury. So that happens once a year, once every other year. So overweight kid with knee pain, get a hip x-ray. It has a high likelihood of being this slip. And then if you do see it, these kids need to be non-weight bearing and they need to go directly to the emergency room. This is a surgical thing that we have to treat right away. And we also have seen kids that have been diagnosed, that have been told to come into our office or what have you. And I've seen a kid who tripped coming into the office. He had a mild slip that went on to a very displaced slip, and the hip really didn't do well after that. And so I would say if you see it, this is one of those things you got to say, listen, you got to go to the emergency room right away because we got to make you non-weight bearing and we got to fix this. So don't miss the presentation of knee pain. And I would say this is one of those things we really do need to treat emergently because it can go bad and we don't have a good solution once it goes bad. Ganglion cysts. So what is a ganglion cyst? This is an outpouching of the joint lining, like you see in this top picture, where you get a little pooching out of the joint lining and some of the joint fluid sort of gets pumped into that little outpouching with a little one-way valve, and it starts to blow up. So it's essentially sort of synovial fluid that gets a little gelatinous in that little outpouching of the joint lining. There's no danger to this. It's non-cancerous, and it's the most common mass that we see in hands in kids and in adults as well. I had a person that an orthopedic surgeon that I trained with who was an orthopedic oncologist who used to tell us that there are 3 places that are common. If it's in the dorsum of the hand, if it's in the snuff box, right in the volar, medial volar aspect of the wrist, or dorsum of the foot, and it's a non-tender, semi-mobile sort of mass, that's a ganglion. There's almost nothing else that can be. I would say that a Baker cyst, which is in the posterior medial aspect of the knee, is essentially just a big ganglion. That's all that is. In adults, it can signal some arthritis or some issue in the knee. In kids, because the lining of the joints are a little bit more mobile, it can just happen it usually happens without any other pathology in the knee. So if it's in those locations, that's what it is. You don't have to have any treatment in here. It can come and go. It can get a little bigger, a little bit smaller. Sometimes it hurts a little bit. Oftentimes it goes away. And I'll tell you that injections into these things and aspirations have like 80 to 90% recurrence rate. So you can do it, or you can send them for someone to do it, but they're going to come back. So they really don't work in kids. So I would say, if this is a typical location and it's non-tender and it's mobile, that's what it is. It's a ganglion, and you can reassure parents that's all this is. It's not going to do anything. It's not going to go away. If you still need confirmation, or if people are pushing, an ultrasound is the best way to do that. You get an ultrasound, it looks like a ganglion, it is a ganglion. You don't need an MRI for this. That's what I would say. And treatment is really education and supportive care. You don't need to over-treat it or over-investigate as well. Hip dysplasia, we still see this. It can be the cause of a lot of angst for the parents, for us, for you guys. And I would say the tips to this is have an algorithm as best you can. And remember the age of the child and the risk factors and the exam really help drive that algorithm. It's obviously better to err on the side of some caution, and imaging as needed is totally appropriate. But having an algorithm that you work through, I think, is the best thing to do. So the risk factors: firstborn female, family history of hip dysplasia, breech presentation, all higher risk for hip dysplasia. And so your antenna has to be up. And when you talk about an infant, this is what my suggestion is. If you have an infant with risk factors and a normal exam in the nursery or early in life when they come to your office, so normal exam, but with risk factors, I would prefer an ultrasound at 6 weeks of age. The AAP says 4 weeks of age, but over those first 6 weeks, you can very easily see radiographic or ultrasonographic hip dysplasia on that early ultrasound. And so earlier ultrasound with a normal exam is not better, because some kids will have a little bit of dysplasia on the ultrasound. That 98% of those kids, if you get the ultrasound at 6 weeks, that early dysplasia or that early radiographic dysplasia totally goes away. So I would say get it at 6 weeks. If it's still positive at 6 weeks, you haven't lost any ground. If it's 4 weeks or 5 weeks or 6 weeks and you start a Pavlik harness in these kids, it's completely effective as it was one way or the other. So I would say 6 weeks is the best time to get the ultrasound. If you have an infant with or without risk factors and there's some instability on the exam, then ultrasound is the next step for those, or refer and we'll get the ultrasound. But those kids almost always need some sort of treatment if you have some sort of feeling of instability on the exam. And I know sometimes it can be difficult to distinguish between hip clicking and real instability, but that's why I say if it's a question, I would err on the side of either getting the ultrasound or referring them over, because if we can see these kids early, the treatment's much more effective and the treatment's much easier. You don't want this 3-year-old girl who was firstborn female and breech, and the exam was a little bit iffy, and then 3 years later she presents because she has a little bit of a funny gait, and she's got these bilateral hip dislocations. So that's why I say image as needed and appropriately, and err on the side of caution to do that. So the two things I would say is that if there's a non-painful limp in a toddler, they're walking around, they're non-painful, then get an x-ray of the hip. That's very likely a hip dislocation or some sort of hip pathology. And it's a dislocation until proven otherwise, is what we tell our residents. And risk factors, but no instability, I would urge a 6-week ultrasound, earlier ultrasound, and we see a lot of false positives. And if you see a real positive, it doesn't put you behind the 8 ball in terms of treatment. So err on the side of early and appropriate imaging. Just, I think, a couple more here. So scoliosis, magnitude and of the curve and maturity are really the things that we look at. So If it's under 20 degrees, no matter what the age of the child, those are curves we tend to observe, because it's more likely than not that those curves will not go on to get bigger. If it's over 50 degrees, that's our surgical indication. And if it's in that middle ground, 20 to 50 degrees, those are kids that we oftentimes will treat a brace if they have growth remaining. If you have a skeletally mature kid with anything under 50 degrees, we don't use a brace. We don't treat those kids, as the risk of that curvature getting worse is almost none. And then I would say the scoliometer is still a great tool for surveillance. And I'm not sure where you get one of those scoliometers now, but there are like 5 or 6 apps that you can get on your phone that have been studied, if you want to read these studies, that are just as good as the other sort of handheld old scoliometers. So I would say downloading that would be appropriate. And if you use a cutoff of 7 degrees on the scoliometer, that'll make sure that about 95% of the kids that have braceable curves are detected and sent to us. Obese kids are a little bit, I would say, a little bit more tricky, and I would use a threshold of 5 degrees for an obese kid, because sometimes it can be a little bit harder. But if you use a scoliometer of 7 degrees, that's totally fine. So if you see kids and you use this and they have 4 degrees, and you see them again next year and they have 7 degrees, that's great documentation and time to refer. But if they have a stable scoliometer measure 3 to 4 degrees, those are very mild curves that don't need to be treated, and they can just be followed, and they don't need x-rays at all. So this is still a great tool to use. This is a 12-year-old girl. She's got this bigger curve. These are things that need surgery, but you're not going to miss these, because with these big curves come big rotational deformities, and so the scoliometer will play that out as well. Toe walking, very common thing that we see. And for me, I tell people the physical exam is the key. So if you have a normal ankle range of motion, then that's what we call habitual toe walking. Those kids have the ability to stand flat on their feet, but they don't like to, or they don't want to. And nothing that we can do is going to make them walk down flat on their feet. If you do the physical exam and they have a tight ankle, they have limited range of motion, that's a little bit different. We can help those kids. We can do something about that. But kids with a normal range of motion of their ankle who choose to walk up on their toes, whether they choose to do it on purpose or they just walk up on their toes, there's almost nothing we can do to force them to get down off their toes. And I would say that, and I tell people this, there's really no long-term sequela of walking up on your toes in kids, okay? They may get tight later on with growth, but they're not going to have any issues with their ankles or their feet or anything like that. So if those kids remain and have normal range of motion and want to walk up on their toes, just reassure the parents. Braces, inserts, casting for kids who are habitual toe walkers, the ability to change the walking with those long-term is almost none. So there's really no role for those things in kids that have normal range of motion. Kids that have tight Achilles that can't get flat, therapy or dynamic bracing or surgery as a last resort are all very helpful, and we can help those kids. But kids with normal range of motion of their ankle, it's really reassurance. So I would say the things to think about are, getting a detailed birth history and neurologic exam is important for all these kids that come in with toe walking. There are some studies that show there's a very high percentage of kids with, quote, idiopathic toe walking that actually have some mild CP or autism spectrum or some other neurologic issues. So thinking about those things and really looking at those kids in that light is important. And then if you have a kid with normal range of motion and they have their ability to move their ankles fully up and down, there's no danger to following those kids. There's really nothing that you're missing in terms of treatment, because we just follow those kids as well, just reassurance. I think this is the last one here, but the multiple fractured kids. So the link between vitamin D and fractures is still fairly opaque, okay? There's conflicting reports in the literature. Certainly low vitamin D seems to be correlated with fracture severity, so fractures that need to go to the operating room because they're so displaced. And low vitamin D is also a risk factor for surgery, probably because of that, maybe one leads to the other. But is there a real link between low vitamin D and increased rate of fractures? That really hasn't been proven, so to speak. I tend to think that vitamin D is still very important and we can make a difference in these kids. And I would say that race and vitamin D, there are also some varying reports of that, but there does seem to be some evidence that that African-American race has lower levels of vitamin D, and that may also lead to some increased fractures. So what we're talking about when we talk about vitamin D and checking it is serum 25 hydroxy vitamin D, not 125, but 25 hydroxy vitamin D. So what I usually do is, if there's a second fracture in a child, then I check the vitamin D. Usually kids fall and they have a reason for having a fracture, and I don't check every kid that has a fracture for vitamin D because I see a lot of kids with fractures. But if they have a second fracture, then I say, we got to check your vitamin D. And if they have a low level, then I treat it. And just remember that kids with darker skin do have an increased incidence of lower vitamin D when they present with the first fracture. So this is a kid treated, he fell off a bike, he has this relatively simple wrist fracture. We treated it, and about 10 weeks later he slipped and he had this refracture and now a new fracture in the ulna. And so that's when you check the vitamin D, and he has this vitamin D at 19. We know that you can get vitamin D from the skin, from the sun, and the recommended level is at 32 nanograms per milliliter. That's normal. And when we ask kids to replete the vitamin D, it's with vitamin D3, which you can get over the counter fairly easily. And this is the sort of the algorithm that we use, that I use, and we give to parents and other people, is that if the range is a little low, 20 to 32 nanograms per milliliter, it's 2,000 international units of D3 daily for 2 months, and then we check the vitamin D after that. And international units is the units that it comes in. If the range is 11 to 19, it's 4,000 IUs daily for 2 months, and then check it 2 months later. And if the range is less than 10, then that's really something that should be referred over to the bone health clinic so we can sort of do a further workup. So it's a pretty good repletion algorithm. Most of the time, the kids after 2 months are repleted, and then they can go on about their way. So that's what I have. I would say that, it's hard to have a comprehensive list, but a lot of these things are okay to treat locally. Obviously, I'm always happy to sort of triage questions with emails or calls or anything if anyone's questioning, and certainly refer when needed. But there are a lot of things that are the consequences. There aren't many consequences to waiting, and some of those common things I would say that can be treated by yourself. One plug here, if you don't know, we've just opened a year ago our specialized Fight for Children Sports Medicine Center. It's a great center. It's right in downtown Silver Spring in the old Discovery building. If you want to come and see it, we're always welcome to have visitors. This houses our sports medicine clinical area. We have a dedicated rehab gym that you can see up on the upper right-hand side. It has state-of-the-art equipment. We have pediatric sports trained physical therapists that deal with athletes or kids who like to play sports. That is a great facility for them. And then we have a brand new motion analysis center where we're going to be doing gait studies and then sports performance and enhancement studies as well. So if you have an athlete that they need PT or they need to see someone, this is a really great center, and we're excited about it and welcome to have you guys come. All right, thank you very much.
Thanks, Matt. We want to see how many questions you can answer in 2 minutes.
Okay.
All right. Question number one. If a ganglion cyst is associated with pain, any indication for surgery?
I would say that surgery as the last resort. We certainly can take a ganglion out, and when you surgically remove it, it's a pretty easy operation. It's about 2 or 3 weeks of recovery and it goes away, but the pain oftentimes goes away without it. So some supportive care and some watchful waiting is oftentimes all that's needed.
All right. Two about babies and hips. Would you recommend a hip ultrasound for firstborn female if the exam is normal and there's no other risk factors, or do you need multiple risk factors?
Firstborn female, I would say no. Breech presentation, family history, I would say yes, if the exam is totally normal.
Do you also routinely recommend hip x-ray at 6 months of age for all high-risk infants to screen for late DDH? on top of a hip ultrasound at 6 weeks.
If the hip ultrasound is normal at 6 weeks, then it's normal, and I don't think they need an X-ray.
Are buccal fractures of the lower extremities managed the same way?
No, only because kids will get up and walk on it, and there's a little bit more issues with pain and mobility, and so we typically will immobilize them and let them walk on it. It just makes them feel better.
You have successfully navigated the rapid fire question sequence.
Thank you very much.